In this short course, I'm hoping to make you confident EEGer in the sense that you will be able to differentiate three cross patterns from each other and act accordingly. You're going to be able to differentiate EEG patterns that are either normal or just slow versus those with highly epileptiform patterns and those that are seizures. Normal or slow waveforms will have no seizures and no epileptiform activity in them. Highly epileptiform patterns are not seizures, as I will explain why and how, but they contain abundant epileptiform discharges that need further attention. And you will also be able to differentiate seizure waveforms or status cases. So if they are normal or slow, it's going to matter. It means we are not going to be aggressively treating the patient. If it's the orange condition, it means the patient will benefit from prophylactic anti-seizure medications and we may consider prolonged recording. And if somebody has seizure, definitely treatment right away. We start with the normal condition. Why is this normal? Because as you will see, there is no departure from baseline. For the most part, all waveforms follow the same mean average, and you have healthy looking frequencies, especially in the occipital channels. You're appreciating a nice alpha rhythm. When the waveforms become slower, as you will see, you have few waveforms to pack between the vertical dashed lines. In the previous slide, you could pack 8 to 12 of these waveforms, especially in the occipital channels. But here, the prevalent waveform has the frequency of less than 8 Hz. Especially if you have an abundance of slower waveforms, 1 to 3 Hz, that means clearly that there is slowing. In terms of the amplitude, make sure that you are looking at the EEG with the scale of 25 or 50. Now on this slide, you see that the left hemisphere, the 4 tracings on the top, have very similar frequency range as the normal one that I showed, but the right hemisphere, the 4 tracings underneath, clearly have slowing. This is the case of a patient who was recorded right after a large vessel stroke affecting the right hemisphere. Again, you are not seeing any epileptiform discharges, you are not seeing major departures from the baseline, and you are not seeing any evolving rhythmic pattern that will be characterized as seizure. This is a clear example of burst suppression. If the entire EEG on this screen was like this, I would have called this status epilepticus. But it is not. It is burst suppression because for the most part, more than 50% of the recording is suppressed. Burst suppression usually refers to a condition where about or more than 50% of the waveforms are suppression and less than those will be bursts of activity. Burst suppression usually doesn't cause brain damage. Hence, it goes with the rest of the blue conditions. Now we are entering the orange territory. It is because in this case you have one epileptiform spike that is characterized by a sharp departure from the baseline. Usually it has 3 phases. It has an up, down, and up type of pattern, and also what we call phase reversal. The phase of this waveform and the phase of this waveform are being reversed right here. Here we are seeing something different. We are seeing some sort of a rhythmic activity that is on the left side more so than the right side. In this case, you are seeing some sort of a unilateral, more prevalent spike and wave discharges. If this is evolving, we call it seizure. This is a clear form of what we call lateralized periodic discharges, but again, the purpose of this course is not to explain the nomenclature to you, but it is to familiarize you with patterns that will definitely need your attention. In this particular patient, the left side of the brain is irritated and is producing these sharply contoured discharges that we call epileptiform. Again, epileptiform because you have this up, down, and then a slow wave afterwards. They are happening in periods of time. Almost every 1.5 seconds, you are seeing one discharge being generated. Therefore, it is periodic. This is highly epileptiform pattern that will need your attention. And if you listen to it carefully, it is not very repetitive or continuous, but yet it is periodic. This is another case of highly epileptiform pattern. Epileptologists would call it generalized periodic discharges because the discharges are generalized to both hemispheres and they are again periodic. In this particular patient, both listening to the left and right will generate the sound of a seizure-like phenomenon. The sonification will be loud scream followed by flat tone, another loud followed by flat tone. Now we go into the red territory. These are cases that needs immediate treatment. This is a patient who's having focal seizure in the left hemisphere. Why is this a seizure compared to the previous ones? Well, it is seizure because these discharges have again that type of morphology of an epileptiform discharge, but is also on top of that not only rhythmic but also evolving in the sense that become faster and faster. And it can be also evolving if this seizure activity propagates to the neighboring channels. So it could be evolving in time, meaning the frequency is becoming faster, or it's evolving in space because it propagates to nearby cortical regions or the ones connected with the source of seizure. In this particular patient, that evolving pattern in the preceding pages has gone into a generalized rhythmic and continuous epileptiform discharges, which is the hallmark of non-convulsive status epilepticus, because I'm not seeing any myogenic artifact. Patient is not having any bodily movement, any muscle tensing, any clonic activity, and this is the case of so-called subclinical seizures. Often patients are lying stuporous or comatose or altered, and yet their brain is seizing away.